Hello, welcome to the Radiology Economics and Policy Learning Electronic Toolkit, Replete. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzak from Emory University, and this module is another part of the series on physician payment systems entitled Physician Advocacy in Action and Evolution. This module is targeted to Level 2 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you're in a program other than diagnostic radiology, please reference the Replete resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows. To understand how advocacy efforts contribute to changing and moving the national healthcare payment agenda. To describe how professional organizations advocate for radiologists and their patients in ensuring appropriate payment and coverage for imaging services. And to identify opportunities to become increasingly engaged in advocacy efforts at both the national and local levels. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. In prior modules, we've talked about the various steps necessary for physicians to get paid for the work they do. In simple terms, you need to get a code, you need to get it valued, and you need to get it covered. And if you don't do all three, you typically won't get paid for that service. But those things don't happen on their own. They require advocacy at every level. And while patients in industry play important roles at all of those levels, most of this all happens because of the hard work of physician professional societies and their volunteer members. We've talked about a number of these opportunities for advocacy along the way, but in this module, we'll put them all together and hopefully illustrate how important it is that this be done in a coordinated and rigorous manner. First, to report a service to a payer, you need a code. We have talked in detail about the CPT code set and the process by which CPT codes are created and modified. This all doesn't happen on its own. Every physician professional organization with standing at the AMA's House of Delegates has the opportunity to have a representative on the CPT Advisory Committee. And specialty societies only have House of Delegates standing if they have a certain threshold of their own members as dues-paying AMA members. So regardless of your political opinions of the AMA, this is why it's critically important that radiologists join and maintain their memberships. You see listed here the various societies in diagnostic radiology, nuclear medicine, interventional radiology, and radiation oncology that have representatives on the CPT Advisory Committee. The RSNA, whose Research and Education Foundation is sponsoring Replete, is one of those many societies. They're only there because enough of the members of these organizations are also members of the AMA. And these representatives are volunteers. Remember that, volunteers serving on your behalf. The CPT editorial panel is a deliberative body that has full control over what gets into the CPT code set and what doesn't. As a general rule, those panel members are individuals who have been very engaged and knowledgeable in the CPT process. They're usually individuals who have previously served as specialty society advisors. Unlike at the Rock, radiology is not guaranteed a seat at the editorial panel table. But we are fortunate to currently have two radiologists serving on the 17-member physician panel, Dr. Dan Pikus from St. Louis and Dr. Kathy Kroll from Indianapolis. And they're only eligible to serve because they are AMA members in good standing, and they too serve as volunteers representing the broader House of Medicine. The 17-member CPT editorial panel elects its 5-member executive committee. Again, there's no guarantee that a radiologist serve on this small group, but for at least the last decade, there's always been at least one radiologist on the executive committee. That's currently Dr. Kathy Kroll. And that important voice of radiology is only there because she has served for so long as a credible volunteer, first for the Society of Interventional Radiology, and then for the AMA on its editorial panel. And she's only eligible to have that voice for us because she is an AMA member. A common thread I hope you're seeing is how AMA membership is the ticket to participate in so many of these processes at so many levels. Getting a code is only one step towards getting payment. Remember that a code needs to get valued, and that happens through the RVS process that we've previously discussed. Just as at CPT, any society that has standing at the AMA House of Delegates also has an opportunity to name a representative as its advisor to the Specialty Society RVS Committee. You see listed here the various societies representing diagnostic radiology, nuclear medicine, interventional radiology, and radiation oncology. As at CPT, most of these efforts are led by or coordinated by the ACR, but all of these societies, including the RSNA, plays an important role here. And those individuals are only eligible to speak on our behalf because enough of us are AMA members. And they too are AMA members. And again, unpaid volunteers serving your interests and mine. The RVS Update Committee makes its recommendations about values to CMS. Here, radiology has a designated seat. That's currently Dr. Zeke Silva from San Antonio, Texas. Once again, he is only eligible to serve and advocate on our collective behalf because he's an AMA member, and he too serves in a fully volunteer capacity. Let's go back to that steps to payment diagram. Having a dollar amount for a service means nothing if a payer refuses to cover that service. That's where coverage advocacy comes into play. The process of securing coverage for existing and new technologies is far less linear than that we've described for getting a code or getting it valued. We've talked about coverage a bit in the ICD-10 module, but let me remind you that there are a number of pathways towards payer coverage. Medicare is where most things happen, and accordingly, that's where most efforts are focused. And most Medicare coverage decisions, at least historically, have been made at the local level through carrier or intermediary advisory committees. So the ACR and several other professional societies have created carrier advisory committee networks to coordinate these activities and have provided staff resources to make the jobs of those volunteers as easy and impactful as possible. But CMS also makes an increasing number of coverage decisions at the national level, where things are far more bureaucratic. That means professional societies can only be effective advocates if they have expert staffs who can deftly navigate these sometimes Byzantine processes, as well as physician volunteers who spend the time and energy to work with those paid staff on behalf of all of their colleagues. Many commercial carriers follow the queue of Medicare, although they are certainly not obligated to do so. But that's why most coverage advocacy efforts start at the Medicare level. That said, the ACR and other professional societies have similarly organized managed care networks of committed volunteers, again working collectively on all of our behalfs, supported by expert paid staff to provide resources and information to help them do their volunteer jobs as effectively as they can. Like codes and valuation, coverage does not happen on its own. Grassroots efforts like these are most effective when they're done in a coordinated and appropriately resourced manner. And that coordination and those resources are what our professional societies bring to the table and why we need all radiologists to be members. It's critical to remember the context of why this ongoing advocacy about coverage is so important. Payers will only cover services they deem medically necessary. And since many payers process literally millions of claims each day, these are rarely reviewed manually. Instead, computer algorithms search CPT codes and ICD codes for matches and mismatches. When a CPT code is submitted and the rationale or diagnosis matches one on an approved ICD list, that service is deemed medically necessary at that level of screening and usually paid. So getting the right ICD codes matched to the right CPT codes on those lists up front in a systematic and official way is critical. It does not happen on its own. It requires committed experts and a lot of resources to pull this all off. And finally, just because a payer says that it's going to pay for something doesn't mean that it will pay enough for that service. If payment isn't sufficient to cover costs, practices and hospitals are less likely to provide those services, and patient access suffers. A great example of how payers can arbitrarily and capriciously slash payments is the MPPR policy initiated by Medicare several years ago for the professional component of the advanced imaging interpretation. MPPR stands for Multiple Procedure Payment Reduction. When initially proposed, CMS made the assertion, and it was based upon a complete misunderstanding of how radiology professional services are rendered, that when physicians interpret two examinations on the same day, they are somehow enjoying huge efficiencies. It's sort of like saying that if you wrote a term paper for one class in college, and the second one you worked on that same day was somehow magically easier, and therefore you should only get half credit from your professor. And so around 2011, with this flawed logic, CMS proposed a 50% discount in the payment for the work of a second study. Take, for example, a day when you interpret a head CT and a gallbladder ultrasound on the same patient. Under the initially proposed MPPR, you would only get half a payment for the gallbladder ultrasound. Through a variety of legislative advocacy work, supported by the Radiology Political Action Committee, RADPAC, as well as peer-reviewed health policy research from the Neiman Institute debunking those assumptions, the ACR was successful in getting that discount initially reduced from 50% to 25%, and finally in 2015 to 5%, to reflect the only modest efficiencies that really are at play. Without such efforts, we would all be still doing much of our work at a 50% payment reduction. These stories illustrate how the role of physician advocacy has changed over time. Back in the day, and this still goes on today, the ACR and other organizations sent staff and volunteers to advocate on our collective behalfs, to CPT, to the RUC, and to CMS. I've already told you about that work. And as I've told you, we also sent lobbyists to Capitol Hill. And that made life easy for radiologists, who could keep doing what they do best, interpreting imaging studies, and getting paid for it. All those radiologists had to do was pay their professional society dues to keep those organizations humming along. And hopefully, some of those radiologists would join the ranks of the committed volunteers who serve us all. But new value-based payment models are changing that paradigm. Not everything can be done for radiologists at the national level. Radiologists will increasingly need to self-advocate at their own individual practice levels. Just reading films will no longer be enough. As we'll talk about in future modules on MACRA and other new payment models, there will soon be as much as a 20% differential in Medicare payments to radiologists who successfully participate in quality-based payment programs and those who do not. So organizations like the ACR are creating lots of tools for members to use. Creating such tools expands the opportunities for organizations to help their members and advocate for them in entirely new ways. So, increasingly, advocacy work will entail giving radiologists new resources to help them succeed, whether they use them or not. As the saying goes, you can lead a horse to water, but you cannot make it drink. That said, advocacy at the national level continues in full force, but it is increasingly changing in nature and increasingly becoming evidence-based, supported by research. It's no longer enough to simply use RADPAC dollars to get access to legislators and go to them on Capitol Hill and say, give me this or give me that. Data to support those requests will be increasingly important. As Deming says, without data, you're just another person with an opinion. And such is the backstory for the increasing imperative for health policy research. In the academic community, we talk about the translational research continuum, where science goes from bench to bedside. Money is incredibly important. Good research is expensive, and so it takes dollars to fund the science and innovation today that translates into our actual clinical practices of tomorrow. But money is also important at the latter end of that translational continuum. Just getting something published in the JAMA or New England Journal isn't enough to translate that science into reality and get it out there to patients all across the country. Most hospitals will not offer new services, and most physicians will not provide them unless they are appropriately incentivized. And so the other two B's in the B2B continuum that are so important and often overlooked are the Beltway bureaucrats, the folks largely in Washington who make many of these coverage and payment determinations. Health policy research and advocacy will be increasingly necessary to get them on board to provide appropriate coverage and appropriate payment. That's where our professional societies come in. I've already told you about the MPPR. That's really the poster child here of evidence-based advocacy. Peer-reviewed health policy research was used to help bolster the advocacy efforts enabled by professional society political contributions to enact H.R. 2029 in 2015. Those efforts, capped by that legislation, reduced the MPPR discount for radiology professional services from 50% to 25%, and most recently to just 5%. For the MPPR alone, this advocacy will return on average $3,000 per year from Medicare into every practicing radiologist's pocket, or collectively more than $50 million to radiologists all across the country. That's a pretty good return on our professional society dues. And that figure doesn't include the many wins at CPT and at the RUC and at all of the ongoing gains at the national and local level from Medicare and many private payers that are much more difficult to cleanly quantify. So in summary, when speaking in a single and unified voice, in support of their own interests and those of their own patients, radiologists are far more impactful than those same radiologists speaking individually. Our professional societies are collective voices, providing ongoing and impactful advocacy. I would encourage you throughout your career to support those organizations with your membership dollars and with your time. To ensure appropriate credit for this module, please make sure that you complete the online quiz from the RSNA's e-learning platform. More information on the Ripley initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in Ripley.